So I'm going to invite up some of our providers to talk about how they play a role in transition. And I want to introduce Dr. Lisa Tuckman, who is a pediatrician here at Children's National. And she has an interest and has been really spearheaded our initiatives here at Children's on healthcare transition. So she's going to come up, and I'll have you guys sit at the table, I think. And then April Barber is an internist at GW and also very active in transition. And then Jennifer Dean is one of our hematologist oncologists at Children's, and she is running the CAP program, which is helping. Yes, no, which is helping our survivors of cancer transition to make sure that they are following up on late effects and staying plugged into the healthcare system. So I've asked them to sort of let us know about their initiatives and their expertise. Thank you.
Okay, so good morning, everyone. Lisa Tuckman. I'm a pediatrician, but I also only take care of adolescents. So I have special training just to take care of adolescents and young adults. I think that the most interesting part of this is going to be hearing from you and your questions. So will tell you a little bit from the perspective of a primary care provider who cares for many, many young adults and teenagers with all sorts of special health care needs. And I think a lot of you probably consider your specialist as your main healthcare provider. Is that true? So if you get a cold, who would you call first? Barbara? Who would you call first?
Primary physician.
Your primary. Okay, so you're unique because a lot of people, I think, when they have a problem that's maybe not related directly to their condition, will call their specialist. They've been through the hardest times with you. They've gotten you through the toughest things. They're the ones who know you the best and seen you, when you've been down the most, when you've been up the most. And so a lot of times, even things like pregnancy, the first person sometimes people call is their oncologist or their pulmonologist. What do I do? So I think it's important to keep a primary care provider. That's my point. Someone that knows you through all the things, that can help you navigate all the different systems that you may be seeing. And so that's important in the pediatric side, but also very important in the adult side. So, and they may also have access to other types of screenings and other things that you need as an adult that the pediatrician or that your adult pulmonologist may not have. So I just think it's really important to try to keep that connection with your primary care provider, have a primary care provider, not just in the pediatric system, but also in the adult system. The only other thing that and I can help with resources and other things, but I think that confidentiality is really important, and that and I think that that it's important to ask your provider or your child's provider how they're going to handle confidential information. In general, we don't go behind your back to talk to your parents about what's going on without your permission, but it's really important, especially in the pediatric health system, because even though we're under a pediatric roof, you're still 18 and an adult under the eyes of the law. I think that's all I have. Yeah.
Can you guys hear me okay? I wanted to share a little bit as someone that's receiving these patients in transition, and as I was reflecting on what I wanted to share, I really thought about kind of two different scenarios. The scenario that I think many of you maybe have described is the relatively healthy young adult who's maybe has one chronic illness. Maybe it's something that I, as an adult practitioner, feel comfortable with, like sickle cell, asthma, diabetes. And the biggest challenges I have really are related to adherence and showing up and understanding the adult healthcare system. When I look at my schedule and I see somebody on there who's under 25, I automatically think, I got about a 1 1/3 chance that they're going to show up today. And if they're new, I could flip a coin because our no-show rate is about 50%. And that biases, I think, physicians, and I think it's good for you guys to hear that, against young patients because they're not necessarily as reliable as the older patients. Now, having said that, I've been working with this learning collaborative for the past 3 years, and I've realized that the adult system needs some work. There are some things that we can do to actually help and reach out and address some of those needs, working with younger adults to get them into the doctor. The other big category of patients are really those young adults with more chronic health problems, maybe cognitive or physical disabilities. Maybe they have congenital or hereditary conditions that I may not feel as comfortable taking care of because I don't see it that often. And those patients, I think, really need that warm handoff, that direct conversation with a pediatrician, or at least some sort of communication. And we've really worked on our communication process with children's in our practice to make sure that happens in a way that makes sense. But I will tell you that in that transition, one of the biggest challenges we find are the parents not really wanting to come. And I get that. You love your doctors. This person knows you really, really well. They know your child really, really well. And the thought of having to go through it again with a completely new doctor, I think, is daunting at the least. And that, I think, has been where we've been putting a lot of efforts. I have a single person who kind of handles that, who talks to the parents, that really works with them on how to get here and what to do when they show up and those sorts of things to help smooth that transition. Those are the experiences that I have as the receiving physician, and the things that we've been working on that I hope are important to you all. And as Dr. Tuckman says, I really think hearing your questions and your thoughts will be very helpful today.
So I'm Jennifer Dean. I'm a pediatric oncologist, and I run the survivorship program here at Children's and in Virginia, and then I work with April and the internists at GW for a program for young adults. And so I have this perspective across both pediatric into adults. I care for our patients. It's a program that we're only seeing patients maybe once a year who were treated for cancer, and we are now long-term survivors, and we are looking at surveillance for late effects. We are not their primary care physician, but that's a piece of it. And so what I've found for transition is we don't have, an exact transition program, but we start to talk to the patients in their adolescent years, and we have one point person who meets with those patients both in the pediatric side and is that same person in the adult side. And then in our team, it's sort of different because we have a crossover. So I see patients here at Children's and in Northern Virginia, but I'm also part of the team at GW. And my role at GW is not to really be the physician providing care to the patients, but I'm the person who is providing education to the patient, to the family, again, going over their medical history again with the patient again, and with the healthcare team of internists who maybe are not as comfortable with late effects with childhood cancer. And so we've found that having that crossover is a great program. It doesn't work for everybody, but it has worked really well. And having the one person who's not me, actually, who's a social worker, who identifies the patients in the pediatric program and is also there for the patients as a contact person in the adult world. So that is my experience, and it's been really good over the last several years.
So I wanted to start with a couple questions, and then I certainly want to include participation from the audience, because I think we have a panel that can really inform us about successes and barriers. But I wanted to start with the pediatrician, since that's where my heart lies. So Dr. Tuckman, when you are reaching that age of independence at 18, because we here at Children's do follow patients until they're 21 or 22, how does the clinic visit change? What does it look like?
Excellent question. So I think it depends on the developmental abilities of each individual. So some individuals will always require some help from families. So we try to individualize, but the things that you can expect. Oftentimes, in our adolescent health center, we have patients come back to the exam room alone. Without their parents. Their parents sometimes are in the waiting room, or sometimes we'll start with both the parent and the adolescent in the room together, discuss what's going to happen, and then the parent will leave for the majority of the visit. Usually it happens stepwise. So at 12, I like to have the parent still in the room, 13, 14, 15, then we start together, hear concerns, and then do the majority of the visit with the young adult by themselves. And, use the parent as available. Actually, we have a policy in our clinic that families can actually sign a waiver or a permission for their child to be seen without their parent. A child could come to our clinic, a children's downstairs, and sign themselves in and be seen with their provider without a parent even there to sign them in. So our model of care changes over time depending on where somebody is developmentally and how the law sees them. And seeing patients alone is also really important to give them practice, to ask questions and to answer questions, because it's much harder if I'm in the room with this gentleman here, and his mom isn't in the room. He has, it's uncomfortable. He'll speak. You'd speak to me, right? Right. So if you can't phone a friend, phone a mom, then it's much easier to facilitate communication or understand why somebody's reluctant to speak. If they're not speaking, then you could say, "You're not saying very much. What's going on?" And talking about it and start to work on that. If it's rather than work around it, but actually work on it.
And Dr. Barber, from your perspective, what are the 50? What does the sort of ideal patient look like who is in the 50% of that coin toss that comes to their new patient visit? How do they look different? What makes that a successful first visit?
I think the things that you all would expect, knowing their health history, their problems, their medications, their allergies. I was really glad you said that. That's a really, really important thing. I think most internists are very happy and understand that much of care is shared decision making, and I expect that with my patients, no matter what age they are. If they have families that are involved in their care, they are going to share that information with them. So I think, like you were hearing about, having some time alone with that patient, but if they have a chronic problem and their parent does need to be in the room and they say that that's okay and sign for that, I think all doctors are very willing and understanding about that. I think the patients that really get the most out of it are the ones that ask me questions. When they're not asking questions, I'm not sure if they're just wanting me to stop talking and so they can leave. And I'm also not sure how well they're going to be able to follow through with what we've discussed. So when patients will say to me, "Wait, where do I go get my labs? Wait, where's my pharmacy?" Then I know that they're engaged and they're paying attention, and I have a lot more confidence that they're actually going to be able to follow through with our plan.
And Dr. Dean, I'm wondering how, if this is an issue, and if so, how you address it. But I would imagine bridging between two institutions and pediatric and adult care. How do you keep the primary care engaged and draw those lines? And what tools or what resources are available to make sure everybody knows who to call when?
So I think we spend a lot of time at our appointments, both in the pediatric side and also when patients come to TAC, talking about just addressing that right off the bat. That, those are, if patients are asking questions, we're going to say those are good things to go to your primary care provider about. And saying to families, if you live far away, we can't be your primary care provider, because if you have a sore throat or a fever or something like that, you need someone who's right there close to you so you can call and go. And what our role is to address, possible late effects and what we need to do for surveillance for those. So we know that's an issue. As an oncologist, I know that's an issue because I get calls from people all the time that I need to redirect to pediatricians. And so I think we're just upfront about it right away. And it takes some redirecting, some nice, back and forth to say, no, actually, we really need you to take that to your primary care provider, and that's okay. So that's what we do.
And I think that there are times when specialists also rely on the primary care provider to help. So, for example, if somebody needed birth control or a special type of antibiotic, and they didn't know the interactions between the medicines that are special, that your specialist knows about, your specialist may not be as familiar with birth control or that antibiotic. And so there's times when they have to communicate. And I think it's also okay to ask them, do you mind, to ask if that's a good question for your pediatrician, for your adult doctor, and then also it's an expectation of your doctor to communicate with that provider. We do it all the time. We communicate between ourselves to make sure that we give you the best care, and so that's also an important expectation, and something that you can ask if it's happening or not. Because again, those medical errors, all those things, so many people are operating in different lanes. You want to make sure that they're communicating. Some of it's your responsibility to bring them the information that, oh, I'm on this medication. How will that interact? But also sometimes we have to also take responsibility for communicating. So you should expect that and can ask about it.
Yeah, I don't know. I think in the adult world, the primary care doc really is the one that's that quarterback or coordinating. And I know that I feel this way, and I think, most of the primary care physicians that I interact with feel this way, that is where all the specialty information needs to come. They are the repository for that information and will help to coordinate that. That's why I think having a primary care doc, especially as you move into the adult, no matter how many specialists you see, I think that is a role. There are some systems out there now where we can get information from other institutions. CRISP is, I think, really going to be helpful. It's a health information exchange that many of the bigger institutions are using, and I think you're going to see that more and more. Providers using that information when they can't necessarily get that. But as a primary care doc, I am all the time sending information back and forth, receiving information from specialists. Our system is nice because at GW, at the MFA, we have a communal electronic health record. So for patients that are seen within my practice, it's easy for us to communicate. But I think this is true in the pediatric system as well. As the primary care doc, that is part of the responsibility that I will take on to help navigate that.
And then we purposely send all the information to the primary care physician after our visits that have, and I do it in the pediatric part as well, that have not only sort of the note of the visit of that day, but a treatment summary and what our recommendations are, that all go in a packet to the primary care provider as well, because we have the same thought that they need to have all that information because they're the ones who are going to help direct all of this.
So you send it to the parents too, the families too?
Yeah,
right.
So after a visit for long-term follow-up, after everything's back together, because it's a multidisciplinary team, a letter with all the information and the lab results and the recommendations and a treatment summary and the recommendations for surveillance all go to the family and all go to the primary care provider. And then once kids hit 18, then we send it to them, but they certainly can share. We're always happy to have, some of our patients get their labs at their primary care physician, so we're always, or somewhere else, if they're going to see an endocrinologist or something before they come see it, we're always happy when they walk in the door and hand us the packet of labs and say, here, I had these labs done, and hand it to us. And we're like, great. And then we can make a copy. They can get scanned into the electronic medical record, and then we have that. So that works really well, too.
Yeah. I think those are great. And I think that, what you're describing isn't unique to this age group. I think that most adults, especially if they have a lot of health history, the thought of explaining and convincing a new doctor of their health history is, it's hard to do. So as physicians, we know that and recognize that. We schedule a little bit more time for our new patients because of that, for that reason. And I think as much information as you can bring, for a lot of these patients, particularly the ones that have physical or cognitive disabilities, and we're doing that warm transition or handoff, we often won't schedule their appointment until we get some information so that we at least have something to work from. And I think that helps the doctor be less frustrated in a situation where maybe you're meeting somebody for the first time and you don't have good information, and you know this person has a lot of health problems, and you feel very, like you can't be the best doctor because you don't have all the information. We're lucky. I have a social worker that works with our group, and so for some of those patients, we will actually have our social worker come in. Patients that have home health services or have different things set up, we often can, if we know what's needed, if we've gotten some information, we can help expedite that as well. But that's the ideal situation. I think what you're describing is probably the more common, where people show up and maybe they don't know everything exactly right. We have ways that we work on that. I think when a patient shows up in my office, they are my patient, and I'm going to do what I can to figure it out. And it may take a little time, and we may have to have them come back next week and call the pharmacy in between and those sorts of things. But if you have that information, if you're bringing that medical summary, if you've got your medication list, those things will really help. And any health history that you can bring from specialist also is helpful too, just to get that doctor up to speed.
Well, first, congratulations for leaving home, for going to college. I don't think it matters. Yes. I think you need to have a plan. So whatever each school has a different level. Some schools are. Some universities are attached to large medical centers. It may make sense to have a contact there. Some aren't. Some are more rural, so you'll need to be more flexible and but you'll have to do some kind of research and work with your doctors to figure out what's the plan going to be. If it's just a sore throat, will student health services be okay? Do the student health services have maybe an office of disability, and they're able to have some health information on record for your child or for your young adult at college. So I think it's just a matter of planning. It always works better when you anticipate and plan rather than react and scramble. So the more planning you can do ahead of time, the more comfortable you are, and things you'll still get a wrench thrown in things here and there, but at least you have some plan in place. But a lot of our kids go to college, and yes, you absolutely need to have some provider where you go, because what if you go to college and then you move to a different city that isn't where where your family is or where you got your care? Then you're going to have to take that information and take it with you. So I would say definitely you need someone where you are.
I will not presume to speak for all adult providers. People probably have, different preferences, but having that information ahead of time is nice, but not too far ahead of time. Particularly when there's a 50% no-show rate for some of these new patients, the providers may or may not look at that until the morning of or the day before. So I think timing that within that week before the appointment is probably the best way to get that there at a time where they're prepared to look at it and think about that patient. The summary letters are actually very nice. Oftentimes when you get a stack of records, this big, you're not going to have a chance to go through every piece of that paper. So having that summary letter, I think, can really be helpful, and thank you so much for doing that.
So the summary letter in hand with our patients, or faxed to you about a week in advance, both? Either. Okay.
Yeah, and I think it's great if the patient brings that summary letter in.
Okay.
I think that's perfectly fine, and it gives them it's some responsibility for them, and I think that helps them understand how important it is that they that communication. So I like that. I like the patient bringing it in.
And I would also say that that it's not realistic to expect a new provider to synthesize 18 years of or 22 or 25 years of records. And so keeping a medical summary is actually something that everybody should be doing on an ongoing basis. It shouldn't be synthesized when you're anticipating a new health system or new provider, that it's something that everybody can have, even if it's just the paragraph that Dr. White was talking about with your medications and your specialists. And actually on the Gut Transition website, there's nice templates in Word that you can modify and type stuff in and keep it as well. That's available for providers that we use in our practice, but also that families can use too, because you never know when you're going to need to go see a provider in a different health system. It's really nice to have that already synthesized for them, so they can really help you with what, they can get through what's happened, your story till this point, so they can really help you with what's going on then.
Well, so I can answer it specifically for the hemostasis and thrombosis patients. As I mentioned, there's a network of treatment centers across the country. So there are 140 centers like ours. Some are peds, some are adults, some do both. So we have access to that list, and depending on whether somebody's going to stay in the area or move out of state or even out of country, we can usually identify a treatment center. Now, obviously, there's only 140, so it's not perfect. And for that, we have additional resources of hematologists, and even those treatment centers, if they're not in the area, often have relationships with other hematologists. And I can hand this to Barbara, and she can comment for the sickle cell
And the other thing
patients.
is that, usually your first visit is often, you do your own research. You can discuss with your providers whether, what you're looking for. If you don't know what you're looking for, then it may be trial and error. That happens often, where you go to see an office and you're like, this is not going to work for me for whatever reason. And then you switch. And that's why it's important to have that loop around, to have a safety net in place. So if it doesn't work that first time, because sometimes it doesn't, and we've found that even with all the support in the world, again, maybe a third make it on their first appointment time to the adult provider for whatever reason, that we know there has to be a safety net in place. So I think you do your best to make the best informed decision and ask questions about who you think will be the best match for you and your family based on the things that are important to you. And then if it doesn't work, then you find someone else. But you sort of want to keep that safety net, which is why planning is important, because you want to have enough time to be able to vet that person and make sure they're the right one for you before it's, you've aged out, of your pediatrics to get your prescriptions filled, to get everything done. So planning ahead is also an important component of finding the right provider to transfer to.
Just to piggyback on what Dr. Tuckman said, what I've done with the sickle cell patients, I've compiled a list of adult providers in the area. And I also rely on those patients when they find more providers that they let me know, and I continue to update the list. And I'm starting to also add other specialties that sickle cell patients will need, such as pulmonology, urology, that are adults in the area as well. But what Dr. Tuckman said, what I've been doing lately is when I'm ready to transition the patient, I have them to go and make their first appointment with the provider that they've chosen. So they'll come back to me after that and let me know if this is the provider they think they're going to stay with, or no, I don't like that provider, let me try another one on the list before it's time to really let them go out on their own. And then contact them later with some feedback. Are you still going? Have you made your appointment? And that kind of thing. So I'm starting to find that that's very helpful as well.
And the other thing I think you have to consider is insurance, because while we have this network of providers, insurance sometimes plays a role in your choice. So that's something that really needs to be investigated in advance. Thank you so much. This has been really helpful. So